Hello and welcome to our panel presentation on injury prevention programs. We will be talking about 4 articles. The first one is from me, Laura Mister, and I will be talking about general versus sport-specific injury prevention programs in athletes. This was a systematic review assessing injury rates.
My name is Katie Mead, and I will be reviewing strength training as superior, dose-dependent, and safe prevention for acute and overuse injuries.
My name is Sam McCauley, and I'm going to be reading Prevention of Lower Extremity Injuries in Basketball, a Systematic Review and Meta-Analysis.
My name is Amethyst Crawford, and I will be reviewing the effect of specific exercise-based football injury prevention programs on the overall injury rate in football, a systematic review and meta-analysis of the FIFA 11 and 11 plus programs.
Please save all your questions until the end of our presentation. We will now begin. So my article was General versus Sport-Specific Injury Prevention Programs in Athletes, a systematic review reviewing injury rates. So my population was athletes ages 11 to 45, and the intervention was looking at mixed injury prevention programs, sport-specific injury prevention programs, and general injury prevention programs. And they were looking at the injury rates after using one of these styles of injury prevention programs. The databases they used were PubMed and Web of Science, and they were able to identify 28 articles that met their inclusion and exclusion criteria. Their inclusion and exclusion criteria was that the athletes must be ages 11 to 45 years old, and they can be from any sports discipline, but they had to participate in an exercise-based injury prevention program, or kept their usual training routine or standardized protocol. The authors then further divided the articles they found into 3 groups using a flowchart that they created, and this helped them identify if it was sports-specific, general, or mixed. And this was a difficult process for the researchers because of the definitions that other articles used when they were writing their articles. For example, an article would say that they were doing a sport-specific injury prevention program, but it would actually be a mixed injury prevention program. And so by the end, they found that they had 20 mixed injury prevention programs and 1 was sport-specific. The results of this finding was that the literature suggests that the mixed and general injury prevention programs have the greatest potential in reducing injuries among the athletes. It was shown that the most efficient strategy would be using one of these injury prevention programs as a warm-up. So this could be about 10 to 20 minutes in the beginning of their training session. And using a wide array of exercises that pertain both to sport-specific and general movements were effective in reducing overall injury rates in their sport. However, they were not sure of the combination and how often they should do more sport-specific or general movement injury prevention programs. While they were doing the research to find all of their articles, they found they had a lack of robustness because they only used 2 databases to find their articles. They said that the reason that they had this lack of robustness was because they were too specific, and therefore they had a limited number of articles that they could use. The clinical bottom line of this article is that the current evidence indicates that general or mixed injury prevention programs tend to be more effective in preventing sports injuries in athletes. However, it is worth noting that sport-specific injury prevention programs are still uninvestigated to date. This data can be applied to the population. As suggested, they can use these injury prevention programs as a warm-up for 10 to 20 minutes before they begin their training. And one downfall to this research was that it didn't go into detail on what specific exercises worked to actually prevent the injuries. They gave some examples of exercises they use in these articles, but the goal of this systematic review was not to identify the best exercises, more so just the best methods, so the general, sport-specific, and mixed injury prevention programs. And their findings were that the mixed and general yielded the best results. We will now hear from Katie Mead on her topic.
My topic was the topic of using strength training as an adequate and efficient injury prevention technique. At the beginning of the search, they looked at 4 different databases. That was PubMed, Embase, Sports Discus, and Web of Science. Out of those 6 studies, 1 study looked at military conscripts, and the other 5 studies looked at soccer players. These soccer players ranged from ages 12 to 40, and they could have been from the amateur level as a recreational athlete, or they could have been an elite athlete competing at a professional level. The only intervention that was considered during this search was strength training. If there was any other intervention that included taping, stretching programs, etc., then they were eliminated under the exclusion criteria. And they measured the outcomes by the number of injuries that were sustained under the strength training program. So each athlete had to enter into the study being injury-free. There were formal tests done to calculate publication bias, and these were tested by Harvard Small Study Effects Test, a modified Galbraith plot, and a funnel plot. And all of these corroborated to prove that there was no publication bias in this systematic review. Lastly, none of these studies any study that was found during the search on the databases that were not reported in English were excluded. It was a part of the inclusion criteria that they must be reported in English, although 5 of the studies were conducted in Europe, and the 6th study was conducted in Africa. Looking across the board at all of the different studies, they found that even though the strength programs differed, none of them were the same. They all were accepted under the inclusion criteria. And even though those were different training programs, the results of those training programs did not differ significantly. There was no significant difference regarding intervention duration. As volume and intensity increased, however, they found that the likelihood of injury prevention that increased. Therefore, each study that was reported increases the likelihood of injury prevention, but the extent of that injury prevention was completely determined by the design of that strength program. Another thing that we need to look at is the compliance rate across all of these studies. All of these studies had a significantly high compliance rate. Each study, when combined together, averaged at least a 91% compliance rate for all of their different participants. Some variations among the studies was found when looking at the types of injuries that were sustained. 4 of the studies discussed acute injuries, and they only looked at acute injuries that occurred during their studies. 1 of the studies out of the 6 looked at overuse injury, and the last study looked at both acute and overuse injuries. Even though this may seem funny off the bat, this allows the meta-analysis to look at a wide range of different injuries. We know that they could sustain both during this time period because some studies looked at entire seasons, others were looked at from 10 to 14 weeks. So this gave a lot of variety when looking at the results of the studies. The only thing that could change amongst them was the volume, the intensity, the RET and SEP schemes, and the program duration. However, none of those changes violated the inclusion and exclusion criteria. When looking at the bottom line, it can be proven that strength training is an adequate and efficient form of injury prevention. They found that a 10% increase in strength training volume reduced the risk of injury by 4.3 percentage points. So as you continue to increase your volume, then it is less likely that you're going to be injured. And all of those studies that were looked at corroborated those findings. When looking at how this relates to a larger population, we found that because all the different types of participants they had in this study, like their age ranges were 12 to 40, that shows a large variety of people. So this can pretty accurately be defined to a larger population other than simply just the 1 studied. Where we run into some issues is some generalizability there were just military conscripts and soccer athletes. Even though the meta-analysis found that the mechanisms of injury tended to be the same across the board regardless of sport, we can say with some confidence that there are going to be different injuries when looking at soccer players compared to volleyball players to basketball players to those who are in the military. There are a lot of different physical demands placed on those populations compared to the athletic population as a whole. So it is encouraging that we found that the mechanisms are similar. However, further study needs to be conducted to be able to say that with confidence. When looking at outcomes, this is really supported by the patient-oriented outcome because the athlete knows if I'm not getting injured, that means that I can play. And that's really that's the main goal of that athlete, is they can continue to participate in the sport that they love. So additionally, going forward, the advice was given at the end of the meta-analysis that regardless, if they do bump up the volume, because the study does show that the larger the volume, the less likely that you're going to sustain an injury. They say that if you are maxing out on heavy weight, that there needs to be a 72-hour gap from maximal effort strength to optimal performance time. So there needs to be at least a 3-day period from that max out time to the time that that athlete competes so that they can recover adequately. And that is very much so encouraged in the study. Lastly, programs were deemed safe for children and adolescents. There is some controversy about whether or not that adolescents and children should strength train, but all of the programs that were looked at across these 6 articles and these 6 studies showed that all of their interventions were safe for children. So at the end of the day, do these benefits outweigh the cost of inducing a strength program into whatever athletic situation that you're in, or the harms of that? The overall increase of injury prevention was 66% across all of the studies. So I would strongly suggest that you put this into your athletic program, just because 4 out of the 6 of these studies reported absolutely 0 adverse effects, and that was 3,991 participants that found absolutely no effect outside of injury prevention for their strength training program. The biggest cost or the biggest harm of implementing this would be the time that the athletes would have to put in, and people who are supporting these athletes would have to put in to prevent this, to practice this injury prevention, and the investment for finding somebody to make the program that works well with your athletes, that works well with the setting that you're in. So overall, I think that this was very beneficial for working towards injury prevention and a very broad spectrum of injury prevention that will not only help your athletes stay safe, but also make them stronger and increase their performance. Next, we will hear from Sam McCauley on her topic.
I did my review on the prevention of lower extremity injuries in basketball, a systematic review and meta-analysis. The objective of this was to analyze the effectiveness of current lower extremity injury prevention programs in basketball athletes, focusing on injury rates of general lower extremity injuries, ankle sprains, and anterior cruciate ligament tears. They used databases for this as PubMed, Medline, CINAHI, and Sports Discus. The population that was studied, they used a selection study that included randomized control or prospective cohort trials, which contained a population of competitive basketball athletes and reported lower extremity incident rates specific to basketball players. This was reviewed by multiple authors, and an intra-rater agreement was calculated using a FLES-K with values interpreted by less than 0 being a poor agreement to the study and 1.0 being almost perfect to the agreement. This consisted of 426 total studies that were identified. Of these, 9 met the inclusion criteria. 1 other study was found during the search of literature, resulting in 10 studies included in this meta-analysis. For the inclusion criteria, the studies were included if they met the following, as the study was a randomized controlled trial. The study contained a population of competitive basketball players of any age. The intervention was designed specifically to reduce lower extremity injuries. Participants remained in either the treatment of control group for the entirety of the study. Lower extremity injury incident was reported in basketball players. Of this information was accessible by the contacting authors, and the study was also written in English and only had from English literature. Throughout the study, they did address the research by stating the purpose of the study to systematically search, review, and meta-analyze the effectiveness of current lower extremity injury prevention programs in basketball populations, focusing on the injury rates of general lower extremity injuries, ankle sprains, and ACL tears. They also did use appropriate study designs by using a modified version of the Reach Efficiency Adoption Implementation Maintenance Framework tool. This test is used to assess the quality of general public health programs and has been used to assess the quality of reporting of sports injury prevention programs. This consists of a 12-item test most relevant to the sports injury prevention. Data was analyzed by a comprehensive meta-analysis and SPSS. The results were showing very good quality by overcoming the hard testing and finding through all of these articles. They were classified into 3 groups based on the anatomical diagnosis reported, as in the general lower extremity injury, ankle sprain, and ACL tear. For the results for an ankle sprain, there were 6 studies that were analyzed for the effect of prophylactic interventions of ankle sprains in basketball players. They were able to find out that both neuromuscular control training and external ankle supports are relative to use in reducing ankle sprains. However, for ACL injuries, there were only 3 studies that were used and only tested by a female population, and they examined the neuromuscular training on the incident of an ACL rupture, which revealed there was no statistical significance to show reduction in ACL injury rates. The clinical bottom line was clearly stated with clear terminology, which included that injury prevention programs are effective in reducing the incident of general lower extremity injuries in basketball players, but needs to be more specific for injuries of an ACL tear. This study only looked at a total of 9 articles to determine if the injury preventions are effective, so they would need more information and more data to specify the needs for an ACL rupture. For limitations for the ankle sprain, 2 of the 3 studies that were examined for the role of the external ankle supports have been performed in an intramural population, which may not have a strict organization or as high athletic demands as other or more competitive populations, which could also lead to bias. So this could lead this out, which would result in having more information and more data for their study. Next, we will listen to Amethyst Crawford in her study.
Like I said before, my name is Amethyst Crawford, and the article I'll be reviewing is the effect of specific exercise-based football injury prevention programs on the overall injury rate in football. It's a systematic review and meta-analysis of the FIFA 11 and 11 Plus programs. So in this article, the population looked at is professional soccer athletes that play in FIFA. And the data sources used for this study were Medline, PubMed, EMBASE, OVID, CINAHL, EBSCO, Web of Science, Sports Discus, and Cochrane Central Register of Controlled Trials. And they specifically looked at studies done from 2004 to the 14th of March 2016. And the inclusion exclusion criteria for this was that it had to be a randomized controlled trial or a cluster randomized trial, comparing the FIFA injury prevention program with a control group that had no intervention among soccer players specifically. And the intervention that was used was the 11 and the 11 Plus program. The 11 program is a less rigorous program, and the only strengthening done in the 11 program is for hamstring, and you do a Nordic hamstring curl. Whereas in the 11 Plus, it's a more rigorous program. They incorporate a lot more like proprioceptive work, and they incorporate a lot more strengthening, and they do more than just the hamstring group in that. They also work on quad, knee, and ankle. So the big question asked in this article was, did it decrease